All right, so this is the Neuro Podcast, Unit 7. And if you want to review the neurosystem on your own, you can go in the book. It gives a nice overview of the neurosystem and the differences in pediatrics and adults. So a seizure is periods of abnormal electrical discharges in the brain, and that can result in involuntary movement, behavioral alterations, or sensory alterations. It can also result in all three. And about 1 in 20 children will have a seizure by age 18, so it's pretty common. Epilepsy is a chronic seizure disorder, so I just want to talk briefly about just because you have one seizure does not mean that you have epilepsy, or that it's going to be a lifelong battle of yours. You know, a child can have a seizure due to many reasons, which include a fever, an electrolyte imbalance, trauma, an infection. And so all of these can result in a seizure, but it doesn't mean that that child then has epilepsy. Epilepsy means that they have this chronic seizure disorder, which is usually associated with something in the central nervous system. And they are recurrent, they're usually not provoked seizures, and it's not related to a fever. The median age of onset is about 5 to 6. You don't need to know the incidence or anything, but just thought I would include it for your information. There are two classifications of seizures. You have a generalized seizure, which involves both hemispheres of the brain. So the abnormality in the electrical discharge is in both hemispheres, whereas a partial seizure, it's localized to one area of the cerebral cortex. So that means that the abnormality in the electrical discharge is only in one area of the brain. Clinical manifestations depend on the type and the duration of the seizure. So if it's generalized or partial, seizures triggered by either environmental or physiological stimuli, and it may be idiopathic as well. And if you want to see page 748 to 749, it just kind of goes over clinical manifestations of seizures. Partial seizures, these, there are two types. There's complex and simple. I'm going to go over complex in a little bit on the next slide. So we'll go to that. So with complex partial, it is impaired consciousness, but they do not physically lose consciousness like they do in tonic-clonic seizures. So they have an impaired consciousness. It happens immediately, lasts about 30 seconds to 5 minutes. They are going to have a postictal phase, and these are more common that you see the aura. So like they hear a sound, or they smell something, or they see a halo around an object, they know that they're probably gonna have a seizure. And so they can have purposeless body movements like lip smacking, lip chewing, sucking. They are actually having a seizure in the part of the brain that controls how you move your lips. Simple partial or a focal seizure, there is no loss of consciousness. It's less than 30 seconds. There is not an aura. With this type, they may have bilateral motor responses or sensory responses. Generalized seizures is what you think of probably the most frequently when you think of seizures, also known as epileptic, grand mal, tonic-clonic seizures. All of those fall under the generalized seizures category. Typically have an abrupt onset, do have bilateral movements, they do lose consciousness, they may or may not have an aura, and it attacks anytime, day or night. Tonic-clonic seizures, the child will fall if they're standing. Again, this is what you kind of think of when you think of a seizure. All of their extremities are moving, they're losing consciousness, their eyes are rolling into the back of their head. They may have a cyanotic period. So if you're in the hospital and have them hooked up to the equipment, and you notice that they are becoming cyanotic, you may want to get them on some oxygen or have oxygen ready if they are becoming cyanotic. Moving on to the next one. Again, they may have a loss of bowel or bladder control. You want that tonic movement, stiffening, last 10 to 30 seconds, and then the jerking can last 30 seconds to 30 minutes, actually. With the loss of bowel or bladder, that was one of the first things we did when we got them into the ER, obviously after we knew they were stable and that their seizures had stopped. But they're in this postictal phase, and so we didn't want them. I mean, who wants to wake up in clothes that are yours, but they are soiled and smell like urine? And so we would always try and get them out of their clothes and get them into a clean gown and clean them up a little bit before they came out of the seizure, just so they didn't wake up, they're waking up in an environment that they aren't familiar with, and just to make them feel a little bit better about themselves. But that's just a little something extra that, nursing can do. We don't have to have an order for necessarily. We just do it because we want our patients to be taken care of. And this was the postictal phase that I was just talking about. They may be confused. They may have some amnesia. They're probably going to be sleepy. They may be difficult to arouse. They may have some slurred speech or poor coordination. It really depends on the child, how long they're going to come out of it. If they got any medicine during their seizure, on how long it takes them to come out of it. The parents are a good resource in this. If they got rectal diastat, it may take a couple hours for them to come out of it, whereas if they didn't get any medicines at home and they just observed, it was only 3 minutes, and they may only, be out of it for 20 or 30 minutes. It just depends. So an absence seizure it used to be called a petit mal. They are not having the typical tonic-clonic movement. It's a brief loss of consciousness, about 5 to 10 seconds. And the attack occurs frequently, so as many as 100 times per day. They don't have an aura. There is abrupt cessation of your current activity and rolling of the eyes. So signs and symptoms of what it looks like. Staring, they may have a slight loss of muscle tone, like a head droop or hands drop the objects. They may have amnesia. They may have episodes that are confused with inattentiveness or daydreaming. So all of these seizures, we're going to talk about medical management, which includes nursing management as well. So what are you going to do if a child comes into your hospital seizing? Well, obviously you're going to get Ativan. You can give that IV. Hopefully you get access and give it IV, or it can be given IM. You can also give rectal diastat if you need to. And they really give rectal diastat if the seizures lasted more than 5 minutes. And that is a home medication that parents have with them and know how to use it. You want to eventually, once the seizure stops, you're going to want to draw some levels and see where their medicines are, if they are on medicines, where their medicines are in the therapeutic range. If they're too high, then you need to hold that dose and let the doctor know before you give their scheduled dose. If the level is too low, then you want to think about, well, have they been through a growth spurt recently? Have they gained a lot of weight recently? What's going on in their life that could cause the amount of medication to not be enough? Or are they taking it at all? You get some teenagers who are older who don't want to just do what they are told, and they rebel against everything else in their life. So why wouldn't they rebel against medicine? And so you kind of, as a nurse, need to assess what's going on with this once you get those therapeutic levels back. Dilantin in particular causes hypertrophy of the gums, so you want to make sure that you encourage good dental hygiene if they're on Dilantin. I'm trying to think of what else I can tell you about these meds. Best case scenario, honestly, is that they are on just one type of these medicines. I know children who are on, 3 to 4 different types of anticonvulsants, and these medicines have some pretty serious side effects and can really cause some developmental delay if you are not on top of it. And so the best case scenario is for the child to just be on one. But if one isn't working, or one works for a while and then doesn't work, they're probably going to continue them on that one that did work and then add on another one until they can figure something out. Nursing management. You can see this page. During the seizure, obviously, you want to protect the child from injury. You want to turn the patient on the side so that they don't aspirate and just observe the seizure activity. Obviously, you're not going to leave the bedside while your patient's seizing, but you just want to kind of, in your mind, jot down real quick when the seizure started and then when it ended. How long did it last? What did it look like? Is this a typical behavior? Once you gather that information, is it a typical seizure for them? Is it not a typical seizure? If it's going on for a while, you may need to get an order for some Ativan to stop it. Be sure you don't put anything in the child's mouth. Again, that's a risk for aspiration. Don't restrain the child's movement and let them do the movement themselves, but do remain with the child during the entire seizure. We talked about it earlier, but monitor for their O2 sats and see if they drop their oxygen levels, and maybe provide some supplemental oxygen while this is going on. And then after the seizure, they're going to come out of it and they're not going to be oriented to anything. So, the doctor may want an AccuCheck or electrolytes drawn, and also would need to be orienting the patient to time, place, person, and what happened. You're going to reassess vital signs, more frequently now. Return the child to the bed or the chair if they fell during their seizure. And then, like I said already, document that seizure activity, what it looked like, how long it lasted, what interventions you did, etc. Febrile seizures are tonic-clonic in nature, and it is usually secondary to infection. So otitis media, you've got a URI. It occurs without evidence of intracranial infection. So febrile seizures are caused by this rapid rise in temperature, from your temperature being norm to going extremely high. The average temperature of a febrile seizure is 40 degrees Celsius or 104 degrees Fahrenheit, so it's very high. And so if you think about it going from 98.6 or 7 degrees to 104 in 30 minutes, that is a huge change that your body has to adjust to, and it can't adjust to it, and so that's why you have a seizure. And its most common ages are from 6 months to 5 years. And the tonic-clonic usually lasts less than 15 minutes. It's the same nursing management as seizures that we just talked about. And medically, these are going to have scheduled antipyretic medications, even more so than those at home. who may have an ear infection or something like that, but we need to make sure that we don't let their temperature have an opportunity to rise above, 99 or 100 again that quickly. So as soon as the parents get a temperature reading of 99.5 or 100, it's time for them to go ahead and start some antipyretics, so either Tylenol or Motrin, and then if an antibiotic is appropriate, go ahead and treat them. If it's viral, it's just got to run its course, but you're going to give that Tylenol and Motrin to keep that child from spiking the fever. It's important that they get one of those every 3 hours, so you do the alternating, and then you need to teach the parents at home to watch for this as well until hopefully they outgrow it. And most people that have febrile seizures don't go on to develop lifelong seizures. It's just kind of a one-time thing. We honestly in the ER probably wouldn't even draw blood work on febrile seizures. If it was their first one, we would look for the source of infection. And if it was definitely, an ear infection and they had a really high fever, then we wouldn't draw blood or anything. We would just give them antibiotics and teach them about, making sure to keep that fever down for the next couple days and send them on home. All right, so moving on to hydrocephalus, there is a picture on 763 that you can look at. This is when there's an increased amount of cerebral spinal fluid within the ventricles of the brain. And so with infants, it's congenital, and older children, it usually is caused by an illness or a trauma, or such as meningitis. Don't worry down at the bottom about what it's caused by. How to diagnose hydrocephalus: you're going to do daily head circumferences, you're going to do a head CT scan or an MRI, or potentially a head ultrasound to look at that free fluid. Treatment: you have got to get that fluid out, and that treatment is VP shunt, so it's a ventricular peritoneal shunt. An infection risk is the number one cause of readmissions for VP shunt patients, and it's because if you think about it, where it's going from the ventricles in your brain to your peritoneum. Well, your peritoneum isn't a clean area. It's not a clean place that you want something that's connected to your brain to go, right? So a lot of times bacteria can kind of make their way up the tube, or the brain gets infected and it's just bad, and so then they have to have a revision. But so it's a huge infection risk. Clinical manifestations depend on the age of onset and the degree at which how high the ICP is in the brain before we realize it and before we get a VP shunt in there. If you want to see on page 764, there is a table about clinical manifestations of hydrocephalus. We're about to go over those. All right, so there's obviously a difference in children less than 2 and children greater than 2. If I were in class, I would ask you why, but I can answer my own question. So if they're less than 2, they still have a fontanelle that's open. If they're more than 2, they're not going to have a fontanelle open. So there is more room if they're less than 2 for that fluid to grow. And so they can withstand a greater ICP in them, as opposed to children older than 2 where they can't withstand that greater ICP. So in children lesson 2, they're going to have a bulging fontanelle. So you want to assess that fontanelle. After any change, or certainly every shift, you want to assess it. They're going to have a head enlargement, so you'll do head circumferences. They may have vomiting, they may be irritable, they may have a change in appetite, developmental delay, sunset eyes. And then increased ICP in children older than 2 years. They're going to have headaches, they're going to have nausea and vomiting, changes in behavior and or consciousness, double vision, pupil reactivity changes, restlessness. It's a hard thing for these kids because there are some children that do so well. They get a VP shunt in and they have no revisions until they get the shunt in at 2.5 years old, and then they don't need a revision until 16, until, their shunt they have now outgrown their shunt. And there's some children that do so well with VP shunts, and then there are other children that just don't do well with VP shunts and have had 40 or 50 revisions on one shunt. And I know there's a child they've had to switch sides on of where the VP shunt goes, because it's just that whole side, they've done so many revisions, there's scar tissue and there's just so many issues, so they've moved it over to the right side, which has issues in and of itself. So it's a hard disease, and it's a hard thing to deal with. And think about how, not only do they have this VP shunt, but then every time they get a headache or every time they have vomiting, they have to go to the ER, because that's what neurology tells them. And then they get to the ER and we scan them, we do x-rays, we do a ton of x-rays and a ton of radiological exposure occurs. And so, it's just a hard disease to deal with. And there are some children, like I say, you would never know that they have a VP shunt and walk and talk and do well and go to school. And then there are other kids that are just in and out of the hospital. So it's a hard illness. So, something else that I wanted you to think about with increased intracranial pressure, particularly in the adolescent population, would be mood swings. They're already having mood swings because they're teenagers, but they can be worse. They have worse ICP. Confusion, change in motor skills, hemiparesis, and then Cushing's triad would be late signs. You're in a lot of trouble then, and they should probably be in the OR. There is something that I wanted to say about hydrocephalus before we move on. This is something that I've seen in my many foreign travel trips, medical mission trips, and it's something that you don't realize how bad it can get until you see it untreated. Here we see or have a baby that's diagnosed with hydrocephalus, and they're automatically going to get a VP shunt. And so their heads are not going to grow to twice the normal size that they should be, or 3 times the normal size that they should be. Whereas in these countries where they don't really have medical care, these babies literally will just lay in the hospital until maybe a surgeon comes who knows how to do surgery on them. But their other outlook is to lie at home, and they're never going to get better. So it's, or, and then even when we do put in that VP shunt in that child, and that child grows, who's going to do that VP shunt revision? Or if it gets clogged, who's going to unclog that VP shunt? They don't have pediatric surgeons there all the time. It's really, I love traveling and I love doing American medicine elsewhere, but our medicine doesn't work in a lot of countries. And you learn that very quickly when you think about a scenario like this. We can go and fix the problem and put in a VP shunt, But how is this child now going to live without a pediatric surgeon on call if something were to go wrong, or if she needed a revision or something like that? So I think there are a lot of ethical issues in doing international care, and the trips that I've always been involved with, we aren't doing surgeries or anything like that. We do dental procedures, but that's the most like procedure type thing we do. But there are a lot of ethical things you need to consider when trying to help other countries and trying to, take our medicine to them. It doesn't go as easy as you think it would, and it certainly doesn't turn out like you imagine it would. So that was just my little 2 cents from a global perspective. But if you ever want to see some pretty gnarly pictures of hydrocephalus, I have some pictures of the hydrocephalus babies in Malawi. I probably could pull some up on the computer one day. And these babies, never got a shunt, and they just live in the hospital. Okay, switching gears a little bit to neural tube defects. This is when you have an incomplete closure of the vertebrae and neural tube, or spina bifida. There are a couple different types, and myelomeningocele is the one we're going to focus on. And if you want to just see that picture, that's what it looks like. So this is when there's an incomplete fusion of one or more vertebrae on the vertebral arch. And you get this sac-like structure that protrudes from the spinal area, which they're in the sac. It's got meninges, it's got CSF, and it's got spinal cord and nerve roots. Spinal nerve roots terminate at the sac and end the motor and sensory function below that point. So we talk about it on the next slide, but the higher the myelomeningocele, the less functions the child's going to have. So they're going to have more deficits. The higher the sac is, the higher the deficits are going to be. So they're going to have less functions. For these, it would be your neuro assessments. You want to monitor head circumference, Q shift. You're going to do neuro checks. These babies are going to be in the NICU, so you can do, more intense care beforehand. So you probably are doing Q hour or Q 2 hour neuro checks to see if anything is happening or changing. And like I said, monitor that head circumference at least once a shift. Many children with myelomeningocele develop hydrocephalus. The manifestations do depend on the location of the lesion. We talked about that a little bit already. And then these, you don't have to memorize these, but just, again, know that the location affects the signs and symptoms that will live with the child. These babies will go to the NICU, and then they'll go to surgery, usually within 24 to 48 hours. That is the only thing that is going to cure/fix them. Post-op position. You are told to never put a baby prone, right? Well, this is the only exception, is they will be prone until the incision heals. And they are probably going to continue to be in the NICU to monitor that incision healing. And so they will keep them prone and monitor them, their vital signs and all of that as well. About 50% will have a latex allergy. They're going to have lifelong issues, like urinary incontinence. So they'll have UTIs, constipation, pressure sores. So bowel training is really good for them, and educate them on that. Moving on to meningitis. We've seen a decrease in bacterial meningitis because of the Hib vaccine, but it does still exist. Children less than 1 year of age are still most at risk, and it happens more in boys and African American children. Can occur secondary to an infection, so you might have an ear infection or a sinus infection or pneumonia, and then it can develop into meningitis, and that is when your meninges are inflamed. So it is a pediatric emergency if you suspect that meningitis. I did see a couple cases of meningitis in the pediatric ER when I was working there, and we did lose a couple patients through meningitis. So it does exist. It does kill patients. There is a high mortality rate if you get it. So the way to combat that high mortality rate is to begin treatments ASAP, and you're going to start broad spectrum IV antibiotics ASAP. You're going to get your labs, blood cultures, you're going to get CSF cultures, and those cultures need to be gotten before you start those antibiotics, but as long as you get those antibiotics, hanging, or as soon as you can get those antibiotics hanging after they've gotten everything they need to get, I would go ahead and hang them. They are at risk for cerebral edema, and hopefully getting these antibiotics on board will help to decrease this. That you can also give mannitol to decrease that cerebral edema as well. They're probably going to go to the ICU, and so they'll be closely monitored there. In less than 2 years of age, you may see a bulging fontanelle. They may be irritable, have a fever, maybe seizures or high-pitched shrill cry, that neuro cry. If you've ever heard it, you won't ever forget the sound of it. You won't see the nuchal rigidity like you will see in adults and adolescents, in children less than 2. You just won't see it. They may refuse to eat. They may just be very tired. Older than 2 years of age, this is more classic sign meningitis that you would think of, with the headache, the stiff neck, the nuchal rigidity, the fever, the chills, change in level of consciousness. Like, this is what you think of when you think of bacterial meningitis. Well, so that doesn't start until about 2, but once they're older than 2, you can think about it in terms of what you would normally think about. And then children older than 2, these 2 signs may be present as well. And so why are the clinical manifestations different for children depending on their age? And it all has to do with the fontanelles. The fontanelles are open, less than 2 years of age, or if they're closed, greater than 2 years of age. That's why their manifestations are different, and why some of our, treatment options and how we take care of them is a little bit different. So, diagnosis for meningitis, you're going to do that LP, which is going to show increased pressure. Excuse me, I'm a little tired. It's going to show increased pressure. There will be white blood cells that are present, which is pretty much the key diagnostic test, and protein, and there's going to be decreased glucose in the lumbar puncture fluid. If there's an increase in the white blood cells in the CBC, that means it's bacterial, and blood cultures will determine the organism. So I would just want to take a moment here and do a side note of a story that really doesn't have to do with really doesn't have to do with neuro, but it has to do with CSF, and so I thought it would be a good place to put this story in. So I was working one day in the ER. It was jam packed with one of my attendings, who is excellent. And a boy comes in to one of my rooms, and he's a teenage boy, probably 17, 16, acting all tough, and he has the chief complaint is stab wound to the back. And I'm like, in my mind, I'm like, okay, so the stab wound could be like pretty bad. He could be actively bleeding, or he could be, it was just a scratch. Maybe he's being dramatic. So you never know what you're going to get when you walk out that door. So I went out the door and got him, walked him back to saw that he could walk, which is always a good sign. Got him back in the room, had him sit on the stretcher, and, I said, tell me what happened. Well, he got stabbed 3 days ago. He didn't want to make a police report. My attending and me both thought that he was involved in drugs and was making money for the family. And so they put off getting him seen as long as possible, because he was the breadwinner. However, he was having some, he wasn't bleeding, but he was having some fluid leak from his back. And so they knew that wasn't normal. So he had a bandage over it, and so there was a definite stab wound, an old one. And we took a sample of the fluid that was around it and did an AccuCheck on it. Now, this is obviously not something that would be condoned, like, without the supervision of your attending, but my attending and I were both in the room, and we were doing it together. And we were getting an AccuCheck of the fluid. So when the result came back, I don't know, I want to say it was like 46. And so she knew some calculation that your CSF glucose should be about 2/3 of your blood glucose. So then we checked his blood glucose, which was, I don't know, 70s to 80s. And so that's where it was. And so we discovered from just doing that he was leaking CSF. And so, which is, by the way, a really big deal, instead of that it was just a stab wound or an abrasion. And so he was leaking CSF and had been for days. So now surgery and neurosurgery needs to get involved, and they need to get to the OR. So that was just an interesting story, and maybe will make you think about glucose and lumbar punctures differently. But you should definitely have white blood cells in your LP for meningitis, and then you would also have decreased glucose. All right, medical management for meningitis. You're going to have IV antibiotics. They're going to be broad spectrum initially until those cultures come back. And once those cultures come back, you may change them to something more specific. Or if it's viral, you can stop the antibiotics. They're usually going to be on those antibiotics for about 7 to 21 days. They're going to want to do a repeat LP 24 to 36 hours after the antibiotic treatment to make sure that CSF is clearing up and getting more clear and doesn't have as many white blood cells in it. They may be on a fluid restriction due to the potential for increase in cerebral edema. So they may be on like 2/3 maintenance. And so monitoring their fluid is very important. They may be on an antipyretic. If they're having a fever, they may be on a steroid like dexamethasone. And so dexamethasone is not commonly given to people with increased ICP. However, the dexamethasone, is trying to decrease the permanent neurodeficits like hearing loss. And so that's usually why you will see that given. And then, if they're like intubated and stuff like that, you may also want to start them on like a PPI or an antacid or something of those natures, depending on how long they're going to be on those steroids. A tepid sponge bath for fever control, hypothermic mattress or cooling blanket, they're ordered. You want to administer antibiotics as soon as they're ordered. You want to dim the lights and decrease that stimuli. You want to cluster nursing activities together. Notify the physician of a change in the child's neurostatus. Pain control, you want to cluster that care because if they are awake and not intubated and able to move, they're going to be in an extreme amount of pain. And so the less that you can interfere with them would be the best for them. So moving on to CP. This is a chronic, non-progressive motor disorder. It's an impairment of motor function resulting from insult or damage to the brain. So either the motor cortex, the basal ganglia, the cerebellum, and they have difficulty controlling muscles, and the abnormality of muscle tone and movement, and they tend to be hypertonic. They are born with it, and we usually first realize it when they're not meeting their milestones. So like they're having difficulty eating, they can't hold their head up, they're unable to sit up, they have hand dominance early in life. I mean, I'm talking like a 6-month-old shouldn't have hand dominance. So those are all signs to look out for and early signs of CP. So these are factors that could cause or play a role in CP. And clinical manifestations are going to have poor head control, failure to sit to crawl, and then abnormal motor performance, so walks on toes, tongue thrust, poor coordinated suck and swallow. So it's usually diagnosed within the first year because, again, they aren't meeting their milestones, but you want them to be diagnosed as early as possible so that they can get the best care that they can for as long as they can. Clinical manifestations, alterations in muscle tone, so abnormal posturing and movements. The persistence of primitive reflexes, like the Babinski reflex, doesn't go away. That's a huge concern. Associated problems with CP and premature birth have very similar problems, and that's because premature birth and CP pretty much go hand in hand. A lot of premature babies do have cerebral palsy, and so they go hand in hand. But visual defects, hearing loss, speech language delay, seizures, mental retardations, they're all associated problems with it. Types of CP, you don't need to memorize this. Just know that spastic CP is the most common, and that's what we're going to go over in our lecture. Spastic CP is the most common. That's where the cortex is affected. And so you have an increase in deep tendon reflexes, hypertonia, flexion, contractures, which we hope to minimize, and persistent primitive reflexes, Babinski, we already talked about that. Nursing management, early recognition, pick up ASAP on milestone assessments. That's up to us. Teach parents motor exercises, feeding and handling techniques. If if the child's not already meeting milestones, you may have to make some readjustments in your teaching and how to educate the parents. And so this is where this comes into play. Some of them may be wheelchair bound, and some of them will require tube feedings. And so you want to promote the child's independence as much as possible with all of these things in mind. And then you also want to facilitate mobility and facilitate them to have as normal of a life as possible. Pardon me. And there's certainly going to be an interdisciplinary team working with them, and they're going to work closely with PT, OT, speech, and special educators. So again, shifting gears to traumatic brain injury. It's one of the most common causes of death and disability. You can see how many ER visits there are. 2 times more boys and girls will go to the ER for this. It occurs more frequently in spring and summer. If you think about it, people, when it gets warm, people want to get outside. Spring and summer, weekends. Again, if it's a warm weekend, people want to be outside. Late afternoon, again, just got home from school, let me get outside. Early evenings, again, just got home from work, let me get outside. So, these occur in the warmer times when people have been cooped up all day, and then all of a sudden they want to get outside. Traumatic brain injury causes, you can read over yourself. They're pretty self-explanatory. Manifestations, it depends on what it is and how bad it is, basically. And you can see the pages if you want to about the different kinds of TBI. It's not necessary. Traumatic brain injury can include skull fractures, concussions, contusions and lacerations, subdural hematoma, epidural hematoma. Traumatic brain injury diagnostics, the most common way is a head CT or an MRI, maybe even a PET scan. Clinical therapy, it depends on the severity of the presentation. So, you've got a kid who was sidelined at football and went helmet to helmet and then became unconscious. So you've now got him on the sidelines with his trainers on a stretcher, and he is not talking to you. So you're going to assess for ABC. So if he's not talking to you, is he breathing? Hopefully. If he's not breathing, then you're going to have to intubate him and get an airway. And then, you'll work on cardiac and stuff later, but make sure you can get him breathing first. You're going to want to monitor the ICP. There's the normal range, and he may get mannitol when he gets it at the hospital. That is to get his ICP down and to help to prevent any further damage that may be occurring to his brain due to this one injury. So emotional support for the child and the family is going to be really, really important after they have a TBI. They can have personality changes, which is difficult for the family because, they had a son who was this way his whole life until he took a bad hit in basketball, for example, and fell and hit his head, and now he's a different person because he had 2 concussions that affected the same area, and so now he's not the sweet kid that they knew growing up. And rehab is going to be ongoing, and so they're going to need ongoing support. Post-concussive syndrome is something that is I wouldn't say it's controversial, but it's received a lot of media coverage, and I really wish that the NFL would do more about this, and even high school players and all that. I wish there was more being done about it as a whole, because we all know it's a huge problem, but nobody wants to seem to want to do anything about it, which is stupid. But anyways, because if you allow, like, we now know what brains look like that have been repeatedly hit against and against and against and against and against these hard helmets for years and years and years. And these brains do not look good, and these people do not end their lives well in a positive or healthy manner. They don't live healthy lives out. They don't, their final days are not pretty. And so certainly for my loved ones, you know, is it important that you are involved in the sport that you love? Absolutely. Is it important that you are allowed to play and be involved in what you choose to be in? Yes, but realize that it's more than that, that it's like something that could honestly really affect the rest of your life, that you may not be able to make it to 50 years old because your brain has been damaged too much. I mean, this is getting heavy and I'm getting off the topic. Sorry, guys. This will not be on the test. So if you wanted to cut it off now, you totally could. I think we need to obviously let them be off the field long enough to heal and to prevent further injury, and make that as clear as possible to the local high schools and middle schools, as well as the NFL and everyone involved. But to specific patients, we can provide rehab and ongoing support, and, you know, listen to them and tell them that we understand what they're saying and that we hear them, and what support services are you interested in, or here are some support services. I encourage you to contact them and all of that. Sorry I got off on a tangent towards the end, but that's all I have for you guys tonight. If you have any questions, please feel free to let me know.